the interest of time, we may allow 1 to 2 sort of very quick questions. Any questions?
I have a question for Michael. How are you managing your 17p deleted patients or patients with p53 abnormalities?
Well, the strategies that have been put forward have been to use high-dose steroids and alemtuzumab. And so far, I haven't found that they've been superior to the FCR approach. But neither of them terribly satisfactory, and I'm really, really impressed with the B-cell receptor antagonists because they're safe. If you use chemotherapy and the very immunosuppressive regimens, many of the patients get too sick to go forward to a stem cell transplant. It does appear that the immune mechanism of control of the disease is satisfactory, and the Germans haven't found that the 17p deleted patients have an inferior response to a non-ablative stem cell transplant than others.
And Anis, a question for you. Are you using maintenance Rituxan in mantle cell?
So the data that was presented in Lugano about a randomized trial in non-transplant candidate elderly patients older than 60 years of age or 65 years of age, randomizing to R-CHOP versus FCMR, then followed by a second randomization to interferon versus rituximab. The data favored the use of R-CHOP over the fludarabine-based regimen and rituxan maintenance over the interferon. Now, this may indicate that the use of rituximab after R-CHOP in elderly patients may not be a bad idea, but keep in mind that the interferon arm did very lousy in that trial. So it's hard to tell what's the contribution of rituxan maintenance. It's open question. It wouldn't be wrong to use rituxan maintenance in an elderly patient if you start with R-CHOP regimen, but I'm not convinced that this is really standard of care yet.
Maybe a follow-up question. Any role for RIT, such as Safflin, in consolidation for MCL?
I'm sorry, what's the question?
RIT.
Radioimmunotherapy. So there's no randomized trial. The phase 2 trial from Mitch Smith from Fox Chase, which was actually a CLGB trial, using R-CHOP times 4 cycles followed by Zevalin, it showed really, again, in non-randomized fashion, if you compare it to other regimens, did not stand out as a home run. And with the Zevalin not being widely used these days, so I don't think this is going to change the practice, although it was interesting data in non-randomized fashion.
Yeah, Jeffrey from Taiwan. I have a question for the graft versus the lymphoma effect after the non-myeloablative transplant. So you show very interesting data that post the transplant, you give the rituximab, and you can see some killing tumor effect. But I cannot understand that. Is the effect is from the rituximab per se, or how can you prove that it is through the graft versus the lymphoma effect? And how about another immune modulating drugs like the lenalidomide or interferon? Thank you.
So this is basically a clinical observation that in patients who have relapsed CLL, particularly after multiply relapsed individuals from other regimens, the use of Rituxan has usually only a short-term benefit. So we were struck by the fact that we have several patients that have a durable, complete remission after Rituxan alone after an allogeneic stem cell transplant. So they have donor-derived T cells that in principle are going to react against the lymphoma, and that is boosted, if you will, by Rituxan coating the lymphoma, and again giving an assist, if you will, to the donor T cells to recognize and eradicate the lymphoma cells. So there is an antibody-dependent cellular cytotoxicity mechanism that the Rituxan induces, where the donor T cells then can kill the lymphoma. And so we can see durable, complete remissions in that situation where we wouldn't see it otherwise. In transplant, there's actually a lot of interest in post-transplant maintenance treatments, both to directly kill the lymphoma as well as immune modulation. And there's a lot of interest in both particimab and lenalidomide that might modify particularly NK cell reactivity against malignancies. And so we're looking at that in protocols with adoptive therapy with NK cells.
Okay, so that concludes this session.